many of the times we need to think beyond mega prosthesis in orthopedic oncology, because many of the scenarios, the conventional mega prosthesis is not possible, maybe because of an age or because tumor location or the tumor tendable bone or some different construction. And I want to share the outcomes of these interesting reconstructions. So I'll be starting with the first case now. This was a 25 years female. She had a pain and swelling in the left ankle for 2 months. She had an hard swelling on around the lower end of a fibula. Someone did an FNA outside, which was suggestive of an anaplastic sarcoma, and then she came to us, and we can see the X-ray, which was completely lytic lesion in the lower end of a fibula. MRI was suggestive of an expansile lesion with multiple fluid levels, lot of cystic areas, and heterogeneous enhancement. So we did a core needle biopsy, and the biopsy was suggestive of an high-grade undifferentiated sarcoma. It was not osteosarcoma as far as the initial pathology goes. So we did the staging workup. Our medical oncologist asked for a PET CT, which was suggestive of non-metastatic disease. And we did a tumor board discussion, and she was planned for chemotherapy based on the standard osteosarcoma 3-drug protocol. Although our medical oncologist used epirubicin in place of erythromycin here. And we gave 2 cycles of NACT because he was not very much sure how much chemotherapy is going to work. But yes, even in the X-ray didn't show much healing in the lesion. The MRI post-chemotherapy showed a little shrinkage of the lesion, but the tumor was still very cystic and it's still not ossified. But yes, definitely the soft tissue component was reduced. So the plan is very clear here. We need to resect the lower end fibula, but the question is how to reconstruct lower end of fibula, because it is a very important stabilizer of the ankle. So we all know people have tried various methods. People have used a non-biological methods like a Prolene mesh suturing with the screws to the tibia and to the talus. But usually with the mesh, it can fail or it can loosen and give some laxity, which will lead to ultimately to arthrosis. I have no experience with 3D printing of lower end fibula. Maybe Dr. Kang can enlighten us on that. But what we planned is a reconstruction, which is a biological reconstruction with a peroneus brevis tendon. And this actually was a published technique by Monson et al. In 2014, where they reported 3 cases with this technique. So this is what we thought we should try here. And that is what we did. After resection of the lower end of a fibula and with a good margins, we identified the peroneus brevis tendons at myotendinous junction proximally. And all of us know how to identify a peroneus brevis tendon. It is more muscular around the ankle, where this is how you differentiate it from peroneus longus. Once we identify it, we have cut it, and then we place a suture anchor around 1.5 centimeters from the ankle joint. And then the peroneus tendon is being sutured to this suture anchor. During resection, you can see we have tagged the anterior talofibular and the calcaneofibular ligaments. First, we suture to anterior talofibular ligament with foot in 30 degree of plantar flexion. Then we use a Richards staple in the lower end of a tibia, and then reflect the tendon back over the Richards staple, and then suture it to the calcaneofibular ligament with foot in a neutral plantar flexion. And then remaining tendon is trimmed or tenodized to the surrounding soft tissues. Once we do that, the rehab usually is that is what we follow, and the same was in the paper, that we keep patient non-weight bearing for 6 weeks, 2 weeks in a slab and 4 weeks in the cast. And after 6 weeks, the patient gets a removable ankle foot orthosis for 3 months. And during this duration, patient starts our gradual weight bearing. And then we continued another ankle support, which is lateral ankle support, for a period of 3 months. The histopathology actually surprised that they called it as a telangiectatic osteosarcoma, which was not seen in the pre-chemotherapy biopsy. The margins were free, the necrosis was very poor. Then patient received 4 more cycles of adjuvant chemotherapy based on 3-drug protocols. The follow-up, we immediately post-op, we can see that the ankle was aligned normally. This is at 18 months follow-up, the alignment was still maintained. And this is the patient weight bearing at end of 20 months follow-up. And we can see that there is no varus valgus instability. and there is no flexion extension instability even after 2.5 years of follow-up. This is our patient walking. You can see she can walk normally without any evidence of ankle instability and without any brace at end of 2.5 years follow-up. So the result was there was no ankle instability and arthrosis. The MSTS was good, and we also concluded the same as by the same similar to Monson et al. Paper is that the lateral ankle reconstruction with a peroneus brevis tendon doing biologically usually gives a very good functional outcome. And this is what we published also in the Journal of Bone and Soft Tissue Tumors. This was a case report only, but then it was accepted because it was a very atypical reconstruction and a very rare site of a tumor. Another case that I would like to discuss is the similar situation. Like we cannot use a mega prosthesis in a small patient, in a young patient, and this is not the best option also. So that is what we faced in this 10-year-old male child with a pain and swelling in the proximal leg for 4 months. The radiographs were suggestive of osteosarcoma in the metaphyseal area of the proximal tibia. This is the MRI. You can see that the disease is going right up to the physeal cartilage, but it is not crossing the physis. We did a biopsy. It was suggestive of osteosarcoma. Staging was non-metastatic, and we had a case with the proximal tibial non-metastatic osteosarcoma in a 10-year-old male child. We gave 2 cycles of methotrexate based chemotherapy in the standard protocol, and this is the post chemotherapy imaging. We can see that the disease is almost the same. There was not much soft tissue component here, and the disease was going right up to the physeal cartilage on medial side, while the laterally there was some sparing of the physeal cartilage. So the concerns that we faced here is, as Dr. Kang is mentioning, like these are the growing children and we need to think of a growth. So that is why we don't want to put a conventional mega prosthesis. Whether to do an intra-articular versus intercalary resection, we know that the physis is a barrier to the tumor spread, but the disease is abutting the physis on the medial aspect. And what reconstruction or what kind of a resection then we should choose, and what is the durability? Similar to like what Dr. Kang was showing, like we can think of a 3D implant, but I have no experience. So we thought we'll use a biological reconstruction. So we planned for an intercalary resection, but yes, there were some issues here. It's like the physis is a barrier, but the disease was reaching up to the physis medially. There's a very small proximal fragment which will be left if we remove the physis and take the cut above the physis, and how to reconstruct an extensor mechanism here. So this is what we planned. We do not have a intraoperative navigation, so we planned this resection on the C-arm, and we resected the distal fragment first, and proximally then we put K-wires in coronal plane, 2 K-wires just above the physis starting medially. We first crossed 1 K-wire completely above the physis, and then we put another K-wire in a different coronal plane just posterior to the first wire, almost a centimeter posterior to the first wire. And then we started taking our bony cut above these K-wires so as to leave a good margin of disease and not to inadvertently enter the physis, and which can contaminate our resection. So this is what I did till up to the lateral medial 2/3 of the resection. I continued the resection above the K-wires till the medial 2/3. And then because I wanted to save some bone in the lateral aspect, and we knew that the laterally there was the disease was not going up to the physeal cartilage, I removed the wires, and then I tried entering, taking the cut through the physis in the lateral third, or tried entering in the physeal cartilage, and that is how we could save some extra bone in the lateral. But as you can see medially, there is only a thin flake of bone left, but at least that could give us a clear margin in this surgery. So this is after a complete resection. And this is the resection specimen, and this was sent for extracorporeal radiation. We got the tumor specimen back and reconstructed with 2 plates medially and laterally. And for patellar tendon, we used a medial gastrocnemius flap and sutured it biologically to the medial gastroc flap, and we covered the extracorporeal bone, as you can see in this picture, with the muscles from the surrounding areas. So this was the final reconstruction X-rays in the AP view. And this is at 3 months follow-up. We can see that the child is having almost normal knee range of movements at 3 month follow-up. He is doing partial weight bearing, and he can do an active SLR at 3 months without any lag. So, and these are the X-rays which shows good alignment in the both AP and the lateral view. Yeah. So this is the child after 1.5 years of follow-up, where we can see almost a normal knee range of movement, no lag, and the child was doing a full weight bearing walking. So this patient has completely healed now, having a almost normal function. So we presented the data of these 10 patients, intercalary section with small distal oblique proximal fragments in CTOS 19 in Japan, where we presented our results, and actually we got a very good outcome. We only one of our reconstruction has failed in small proximal fragment where there was an implant failure, and then we need to revise it with a bigger plate. So, but yes, usually these are challenging situations, and if we are able to get a good fixation hold in these small fragments, then more or less we are getting a good outcomes. Now we have started actually customizing our special plates. We're not using 3D, but we have actually designed a special distal femur plate so that we can get a good screws in a small child and good hold in a smaller fragment. So going to the third case, this is my last case which I want to show. This was a 23-year female with a pain and swelling in the left knee for 1.5 years. And clinically also there was a swelling in the proximal tibial region, no lymphadenopathy. The radiographs, these were looking like a benign lytic lesion in the proximal tibia, most likely a giant cell tumor. Similar was the MRI, but as you can see in the axial image, there was a huge anterior soft tissue component of the disease, and which was actually going in the full area of tibial tuberosity. The biopsy was a giant cell tumor, and we know it's a Campanaki 3 giant cell tumor. So the option was either to resect this and put a prosthesis because the extensor mechanism was involved. There's almost a full condyle is involved, to give initially denosumab and plan for a curettage. But we know with giving a denosumab, the recurrence rates are high because we are usually not able to do a complete curettage. Or we thought we'll straight away go with the curettage, something like an excision curettage, where we resect the complete anterior cortex and the tibial tuberosity, and then try fixation with the cement and do something for an extensor mechanism reconstruction. So that is what we did, because we thought there's a posterior cortex which is intact. We did a thorough intralesional curettage. We filled the cavity with bone cement and a plate, and reconstruct the soft tissue with a medial gastroc flap with reattachment of patellar tendon. So this is a bone window that we created, and we did a thorough curettage, used high-speed burr, used pulse lavage, and we used hydrogen peroxide as adjuvant. We can see there is no anterior bone which was left, and cavity was stabilized with a plate, and then it was filled with the cement. The arrow is pointing to the patellar tendon, which was then sutured to a medial gastrocnemius flap, which we did, and the tendon was sutured to this gastroc flap. And you can see the post-operative X-ray, the cavity nicely filled with cement, although there is no tibial tuberosity now. And these are the radiographs at 1 month of a follow-up, 3 months follow-up, and now 30 months follow-up. And this is the patient's function, almost normal knee range of movement, no lag, and no recurrence. So that is what we want to highlight. In giant cell tumor, the most important thing is a complete curettage. Sometimes we need to do an excision curettage where we need to excise the soft tissue widely and then do a curating of the bone. And then we should plan a reconstruction. But in a young age, we tend not to use a mega prosthesis and tend to save the joint as much as possible. And this is what the literature also suggests, that cement is a very good filling agent in a giant cell tumor, and the recurrence rate with cement is low. And the other papers also suggest the similar thing. And then the risk of cartilage damage also, as suggested by this paper, which is a small study, but then they measured they saw the X-rays, MRI, and measured the cartilage oligometric to matrix proteins in follow-up, and they found that there is no evidence that suggests a long-term presence of cement close to the joint will lead to a degenerative arthritis. It is mainly because of the mechanical reasons rather than the cement-induced damage to the cartilage. So this is what I would like to show today. Thank you very much for patient listening. Thanks a lot.